Faria and Nick has a look at all your posters, all your contribution. They have make a summary, and now they're asking me on live to comment on it. So it's like a little bit of a radio live show. Is that right?
Yes.
So maybe you can sit there,
okay.
And I call you if I don't follow what you mean.
Awesome.
Or you correct me.
Okay.
It's a live show, right? So you tell me if I've not understood the point that you make, right?
Yes.
Okay, so let's go. I'm discovering, like you, what your wishes. So the biggest impact of Blepharospasm on my quality of life has been independence. And you say help to keep my job, loss of career age 45, loss of independence, and impact of my day-to-day life and independence. That's clearly related to the loss of eyesight. Because really patients with Blepharospasm are functionally blind. And it's so difficult to understand for people around them what does it mean. They are not blind. Yes, they can see, their eyes are good, but they can't see. It's what we call functionally blind. And it's this ambiguity which makes these patients so, it's hard because they can't convince the people around them that they are functionally blind. And when you talk about blindness, you talk about loss of independence. And I've seen so many patients after the age of 60, 70, 75, 80, who say, look, doctor, I have to choose coming to see you being injected or going to a nursing home. And I don't want to go to a nursing home. And I've seen so many old English ladies, but so fierce, so want to keep their independence. I mean, it's fantastic. And they manage to do it. And they come and they take the train. And it's really a fight. And I'm very impressed by my patients. And the people who say Blepharospasm, they get a little bit anxious, depressed. What I see is that they're really fierce and fighting. And they want to be independent. And it's clearly what the first things to come. I think you got the right point. And of course, if people are younger, it's keeping the job, it's keeping the money coming in the home. Other people assumption. People assume I cannot see, is what I say, functionally blind. People, do they believe me? They don't believe me because I'm odd. I got a rare condition. It's a functional thing, and people don't believe me because sometimes my eyes are open and sometimes my eyes are closed. And all this capricious progression is very disturbing for others, and people don't take them seriously. It's very painful. And driving, driving, and it's not. The DVLA is not coping with the certificate for Blepharospasm patient at the moment, I can tell you. 2-3 months before it was quite quick, but now it's not. And it's a challenge. The patient said, doctor, you're going to do my DVLA form. Do you think I can drive? What's going to happen? And so on. And driving, it's independence. And I said to my patient, avoid driving at night, because we see that moving light, flashing light is not very good. So I always say, if you are well controlled by the injection, please drive. But because I don't want that they lose their independence, but be careful at night. Activity of daily living, yes. I don't know if the loss of balance is something pertinent, but maybe we will for the cycling. Stress events, and we talk about that. 100% worse before Botox. Yeah, I think the Botox, I know Botox is painful, Botox you don't know, Botox has to be adjusted. I'm old enough to have done clinics of Blepharospasm before the Botox. I was a research fellow of David Marsden, 84, 85. There was no Botox. Botox works, I can tell you. It changed completely the prognosis of Blepharospasm and every focal dystonia. I mean, if we did not have Botox, it was really hard to manage. Getting named under the Equality Act to get more job employment protection, reasonable adjustment. I think that we were talking with the guy Parker, the CEO of the Dystonia Society, that maybe he has a long experience of employment and protection of people. And I think we want to develop that at the next British Neurotoxin Network to help consultants to help their patient to do the proper certificate, the proper paper, to protect our patient. We are here to protect our patient. And it's very interesting that you say that, because I say to guys at lunchtime, please give a talk. You are here, guy, yes. And he's very good. He worked in that field before. And I say, can you give us a talk on, tell the consultant how to protect patients from that? And I think he's going to help us. So that's fantastic. Research in blepharospasm treatment. Certainly we know, and there is a big field now, we saw when we look at the anterior cingulate, and we know that the mind is in the brain, and now we can split the patient, and we have to consider mindfulness and the impact of stress, and we know that. And there's a lot of functional MRI now to see the impact of mindfulness, and it has an impact. Huh? So now we are getting more and more open, even trained academic doctor. We are not homeopath or osteopath, but we are very open now. We have changed. So that's good. The tint lenses, for some patients it works, for some patients it does not. So I'm a neurologist, so I'm not very good to communicate about that. But I think more fielders communicate about that. Some sort of probe be designed to work out what side the Botox need to actually be injected. It's not a probe, but I've seen some recent paper doing some mathematical model. And it's very interesting and computerized model to understand which will be the right dose and how to adjust the dose and so on. It's very interesting because we agree it's not, it should be improved. I see that Dan is making sign hurry up. Symptom control, the impact of my site. The site is good except if you have a diplopia, and it's happened to every injectors that patient can have a diplopia, especially if they have a previous history of strabismus or lazy eyes. We can decompensate that with the Botox. Looking downwards is fine, but upwards is awful. That's what Mej say in 1910. We agree with Mej. Looking downwards is fine. So that's the reason the patient can carve, sew, do little broderie, and it's fine. And as soon as they look up, it's closed. But we really don't know what does it mean, but it's true. And also, I will say that when patients have to look down and they are very attentive or something, and the key in dystonia is to distract your mind. It's that reason, the sewing, knitting, doing anything. And now the new people, the one who have cervical dystonia, who are just more younger than you, what do? They have little funny, stupid game on their iPhone. And they play the game. You know this game, yeah, you press, like a teenager. And this releases the dystonia. Because it's engaged their mind in just things which distract their mind. And bien sûr, if you're older, you knit or you sew, but you can also just tap, and it works. So it's this distracting of the mind is very interesting. And next, cause of the condition, if the brain could have any effect on dystonia, I don't believe that the condition is psychosomatic. No, we don't believe the condition. The condition is not psychosomatic at all. Huh? It's not eczema. Huh? That we are very clear about that. It's not because of stress. Stress influences a tremor of Parkinson's disease. Parkinson's disease is not psychosomatic. Stress influences the severity of dystonia. Dystonia is not psychosomatic. I think stress influences most of the brain disease. It doesn't mean it's completely different psychosomatic disease, okay? That's not that. Explore plasticity, we agree. Norman Deutsch, I don't know, sorry, I pass. Current problem is the appearance of drooping. Yes, so that we talk about that with Dan, and it's when you close, and Doreen also, she will know as the ophthalmologist, when patients close, sometimes they have a detachment of the levator palpebrae, and they have a permanent ptosis, even if the Botox is helping the spasm, and the surgeon love it. Oculoplastic surgeon, they do much better than Botox for that. But it's rare, it's long-standing blepharospasm. But if you have a permanent droopy eyelid despite having no more spasm, it's maybe you have pulled too much on your eyelid. And if I have blepharospasm, glaucoma, and blepharitis, you're not lucky, will it cause a problem? if I have the cataract removed. No, I usually advise the patient to remove their cataracts a month after the injection, because you are at the peak of the injection, and because they love to do it without general anesthesia, you don't need to pull too much. So try to organize your cataract a month after your injection. Glaucoma, the close-angle glaucoma has been described to be possibly precipitated by Botox, so you have to tell your doctors. Also, anticholinergic, which can be prescribed in blepharospasm, can precipitate glaucoma. So please always mention the glaucoma and the type of glaucoma you got. Blepharitis can be associated with blepharospasm. There is a lovely leaflet from Montfield to how to care for your blepharitis, and I give it to my patients. It's fantastic. I remember it's baby shampoo from Johnson that you put with the cotton pad. It's fantastic things. And
product placement.
sorry. This is the most important thing I've gained from this meeting so far is that it's possible to have dual diagnosis with yes, it is. You can have blepharospasm with other things. You can have blepharospasm with Parkinson's disease. You can have blepharospasm with eye disease, yes. That blepharospasm don't protect you from other disease. I have had blepharospasm since 98. Much more interest in it now. Yes, it's increasing, because I would not have imagined such a day in 1998 for sure. And the word community research is completely new for me. It's fantastic. Community research. It's really stops this relation between the patient who are condescending to the doctor condescending to his patient. I know you don't. I mean, it doesn't exist anymore, and I'm very impressed how we are progressing on that. And hearing about the experience of other blepharos, certainly. I mean, to have peers, to be in community, to be strong together, to have lunch with people, to connect, you are stronger. That's very, very important. I completely agree with you. And also doctors, we need to have other, be specialists of blepharospasm together and have a coffee. We feel stronger. And we do that with the British Neurotoxin Network. It really works. Research concentrate of more accurate diagnosis. We all agree we need training, but I think the big step has been the keyword of Google, and a lot of patients now are self-diagnosis from the internet. Because patients with blepharospasm, any dystonia, they know what they got. And I remember with David Marsden in the 80s, when we were doing a radio program on writer's cramp or cervical dystonia, patients were ringing and coming to the service, the department, and they have the condition. Patients can easily diagnose themselves if they hear about. So it's very powerful, the website. Better monitoring, yes. Because I'm not anymore NHS, I've improved the monitoring with asking the patient to email me, and I copy-paste the email in the electronic notes. But the trouble in the NHS, they still have this confidentiality business. So they don't like patients emailing them. But otherwise, emails are so precious. If a patient emails you at a month's time, he knows what's going on, or at 2 weeks' time. And sometimes he forgets a script form and say, you told me that. And it's so precious, the feedback at the time. So maybe do email to yourself and bring them to the doctor, right? And I say also to the patient, take short film of yourself. If you have a side effect, take a picture of yourself, show it to the doctor. It's so quick the next time you go to the clinic. Very powerful. Finding what causes the disease. Yeah, I hope I will die one day knowing the cause before. Honestly. I mean, we know that's mainly genetic and environment, but I mean, there is a new gene which just been published, recessive form of adult onset focal dystonia. And every year or every 6 months there is a new gene, and it's very, very encouraging. So yeah, we will find it. Better emotional and social support, yes, I agree. That's a very, very important. But I think you have been heard, you have a day like that. So, and really there is a lot of research on the mental aspect of dystonia, as I say. So I think it should progress. And that's it. No. Apart from treatment, I wish research would concentrate, finding out what's caused, yes. Faster and more, we agree, better monitoring, yeah. Okay.
It's just to show which one's the most important. So finding out what the causes of the disease. The orange essentially shows, so they were graded 1 to 3, 1 being the most important, 3 being the least important. And what the pie charts are trying to show is that the orange.
Can you stand up?
Sorry, yeah. So if you look at the orange on finding out what causes the disease, that was by far the most important factor out of all the questions we were asking for this poster. Whereas if you look at the emotional and social support, actually no one ranked that as the most important factor, which is interesting.
It's interesting because finding the cause of the disease is finding the cure. But I mean, I was abrupt to the patient who say, we are not God. Huh? We all wish that to have the... I mean, I really sincerely hope that one day I can stop injecting and treat the patient with a specific drug and done. But I don't know if I'm going to see that. You see, that's, we all hope so. And we have a professor of pharmacology here, and we have seen papers and trials which are projecting to try some very specific anticholinergic drug with no side effect on the memory. We will trigger the dystonic phenomenon. But yeah, maybe in 5, 10 years, but we will have it. Of course, there's research on drugs, there's research on better Botox, there's research for the surgery, for the deep brain stimulation. Of course there is, but not in the next 5 years. It's still a long way to go. Sorry for that. But it will. People are doing that. Of course, we all want to know the cause and the cure. We all want to know the cause and the cure, and we are aware that what we are doing is far from perfect. Otherwise, I will have not spent my Saturday with you. Thank you.